Kia ora. I'm Dr. Janine Bycroft, the Clinical Director and Health Navigator, founder of Health Navigator Charitable Trust, and delighted to have Dr. Rebecca Grainger with us here today, rheumatologist and one of the trustees for the board. So we're delighted to do this Facebook Live, and hope you're all going to join us shortly, and we'll go through some of the questions that we've received.
Well, I think it's my turn to introduce myself. Kia ora koutou. My name's Rebecca Grainger. I'm a rheumatologist based in Wellington. I've been a rheumatologist for well over 10 years now. I see people with a variety of, in medicine we say musculoskeletal complaints. Actually that usually means part of their body hurts. In my public hospital practice at Hutt Hospital. And my main disease is in inflammatory arthritis, osteoarthritis, and I see a lot of people with fibromyalgia, or as I like to think of it, I tend to use the words chronic pain syndrome or pain sensitization, which is actually just a technical way of saying a lot hurts and doctors really can't find a single explanation. You must see a lot of that in your general practice as well, Janine?
Yeah, absolutely. Pain and difficulty sleeping are two of the most common problems we see, and they're not always that easy to manage because there's not a lot of easy, simple solutions for them. But the key thing is there is a lot people can do to help themselves, and it's just about going through systematically what some of those things are to make a difference.
Well, it sounds like you're on a similar page to me about looking after what people, seeing what they are able to do.
Yeah.
So we did ask for some questions to come through ahead of time, and I'm just Charmaine's going to pass me a piece of paper over here so we can have a look at what came in. So one of the questions that came through, which was really interesting to me, because I've done some work about rheumatologist attitudes to complementary health, because often conventional medical doctors can appear quite negative about complementary health. So we did a little bit of work on that space, and the question is, what alternative treatment or therapy could you suggest for someone with ankylosing spondylitis? So I think that's a really great question, but what I'm going to do first is just actually encourage the person who asked the question just to think a little bit about what their current conventional management for their ankylosing spondylitis is. There might be some room for movement there, and that would be something to discuss with their rheumatologist. And then the second question I would usually ask this person is, what is it you want to see get better? You know, what is the problem that you're trying to address? Because any treatment or therapy or lifestyle choices or activities we engage in or don't engage in for our health, you've really got to think about what you're trying to improve, and then you can ask the question about what might be helpful in that space. In terms of, because actually in Western medicine what we tend to do is look for information from clinical studies that says if something is useful or not, and one of the problems with alternative treatment or therapy is that often those studies haven't been done, so it's a little bit difficult to give advice in that space. Now, we've got any questions coming through that you can see, Charmaine? Okay, well, oh look, here's one. Welcome, Kelly. I can see you've just managed. If it makes you feel any better, we were a little bit tech challenged as well. The whole setup had been practiced at home, but we're actually at ProCare in Auckland tonight, so we had a little bit of tech challenge, so we know exactly how you feel. So we're with you on that one, Kelly. Welcome. Now, I'm just looking down for some other questions, and I think I'll address another one further down because it links in with the top question. Do you know much about treating pain related to psoriatic arthritis? Well, my answer to that is yes, I hope so, because that's what I do for a job, manage psoriatic arthritis. And what my general approach to management of pain in psoriatic arthritis is to try and understand if there's a treatable or reversible cause of the pain. So the things I look for first is there active inflammation, which is a hallmark of psoriatic arthritis when it is in an active state. And I'm reasonably good at treating inflammation, either with anti-inflammatory medications, local steroid injections or some of our what we call disease modifying drugs. So treating the cause is helpful. The second thing that can happen in psoriatic arthritis, and it really depends how long you've had it, is if there's any damage to the joint, there might be some treatments that can help with pain there. And then if there's no specific reversible causes related to the actual underlying disease, we look at if there's been any what we call pain sensitization. There's a really common problem if someone's had a painful condition for a long time, even once the cause of the pain's got better, the brain's been what we call sensitized, like the volume's turned up, and you can still have the experience of pain, but the actual damage to the tissue has gotten better. So
that's a really important point. Rebecca, do you want to just tease that out a little bit more, because it affects so many people living with chronic pain from any cause, doesn't it?
So we've got 8-year-old twins, and I've watched how they learn about the world, and it struck me that when we learn about pain, we very much learn something bad happens to a part of my body and it is painful. So you step on a nail, you put your hand in a fire, you've got damage to the tissue and you feel pain. And the only reason we feel pain is to protect our bodies. So you take your foot off the nail, you take your hand out of the fire. So in that instance, pain is really useful. But what can happen if it's not a single event and it's a chronic painful condition is the brain gets this message coming up day after day, hour after hour, that there's tissue being damaged, and that part of the brain actually gets, I sometimes say to my patients, it got fried. It's like a short circuit. It actually gets buzzed and is sensitized, so like the volume's turned up, and even when the damage in the body has gone, the inflammation's resolved or something's healed, that part of the brain is still buzzing. So the person still feels pain, but there's no damage to the parts of the body. And that's really hard to understand, because we've always learned a thing happens, we have pain. And I'm asking you to unlearn that and think about pain in a different way. Some people feel worried when they get this inflammation, because they say things like, oh, you're telling me it's not real, it's all in my head. It's real. It's so real, because it's really intrusive and is there all the time and really affects people's quality of life. And yes, it's genuinely there in the way you sense pain, but it's not there in the terms that there's damage happening in the other parts of the body.
So the question, of course, is what can people do about that?
Well, there's no one thing they can do. There are some medications that can help, often indirectly. For example, using medicines that have traditionally been used for treating depression at low dose can help. They probably help mostly because they're quite sedating and make sure you have a good sleep. And that goes on to, once your brain is a bit fried, part of the important thing is unfrying the brain and unwinding the stress that often goes with chronic daily pain. So there's probably no one thing, but I talk with my patients through a menu. How's your sleep? How's your eating? Are you doing exercise? Now, exercise is a really good stimulus to reset the brain. Suddenly you're doing different physical movements, and it might actually remodel part of the brain. So regular exercise, whatever you can manage. Is there a lot of stress in your life, either caused directly by the pain or for other things going on? And actually sharing it and getting support from other people similar to yourself. And one way that can help there is some of the support groups that Arthritis New Zealand runs. Hey, I can see there's some questions coming through. I'd really like to have a look at these comments. I wonder if I can click on this. Let's see how our tech is. No, there's a whole lot of people that like this. If I can see a question. Oh, okay, Kelly's, there's one here I can answer. I can begin to answer with Kelly. Kelly's asked, wondering how to lose weight when on prednisone and sore feet and ankles with rheumatoid. That's a hard place to be in. And the trouble with prednisone is it really drives your appetite, and so you eat more and then you put on the weight. But usually the underlying condition means you can't do the physical activity to maintain the weight. So first of all, prednisone should only be used for rheumatoid arthritis for relatively short periods of time, and the dose should be the lowest that's effective. So it'd be useful to talk with your rheumatologist or your GP about how the dose of prednisone can be brought down to the lowest level that's appropriate for you. The second thing is, I'm wondering, and you don't need to answer this, it's just a wonder out loud, is if you're requiring ongoing prednisone for longer periods of time, probably need to look at what other medicines might be useful for your rheumatoid arthritis so you can minimize the dose. Then losing weight, although it's difficult on prednisone, you've got to look at all the things any of us need to look at, what we're eating and how active we are. And actually Health Navigator's got lots of really good information about how to look at and think about your food and make the best food choices for you, and also ways that you can get active even when you've got pain. I often say to people, getting in a pool is a way that if you've got sore feet or ankles can be helpful. And sometimes a stationary bike or cycling can be better on joints.
Yeah, actually, I know when I have any patients with knee problems, the specialists seem to be get a bike. Get a cycle, and just it's not weight bearing, but it just gets those limbs moving still.
So what I tell people is go to Trade Me, because there's heaps of people who bought a bike, have got an interest in sitting in their garage, and you can actually put them actually quite close to new, not very expensive. One of the other things, if you've got knee or hip problems or ankle problems, is have to have the seat a little bit higher than you traditionally would, because you're going for a slightly smaller arm, so that can make it more comfortable.
Oh, that's great. Okay, we've got a question here from Lionel Marsh.
I have arthritis in my knees. I take 1 celecoxib daily. This takes the edge off, but I still limp and feel pain. I'm sorry to hear that. What is your go to pain relief, and do they require that I take Losec to prevent an ulcer? I'm told by a friend you can get slow-release tramadol and other more effective pain release. Slow-release Voltaren did not really help either. Well, that's a challenging one. There's a few things in there that I probably can't answer specifically because it would depend on your other health problems. I think it's really good you're asking questions about anti-inflammatories. They are often very, because celecoxib and the Voltaren that you've mentioned are both in the anti-inflammatory class of medicine. There are potential harms that can come with those medicines, so I'd encourage discussing them with your doctor. I often recommend Losec with most of the anti-inflammatories. I'm going to wind you back a little bit and talk about use of paracetamol, because it's probably much safer than anti-inflammatories. You do need to take it regularly, and you probably need to take it regularly for a period of time, because there's likely to be a little bit of pain sensitization here. You actually need to break the cycle.
So by regularly?
For most people, that's 2 tablets, which is 1 gram, 4 times a day. For some people, if you've got other health conditions, it's 3 times a day. So a maximum of 4 grams a day for most people, which is 8 tablets a day divided up. What I am going to say is also take you back a step and see what non-medicine pain relief you're doing. Self-massage can be useful. Some of the topical agents, topical rubs can be useful, either by direct effect or by the actual just the massage. Ice at the end of the day can be helpful. And the other thing, and this is going to sound counterintuitive to you, because you're limping, so I imagine exercise is difficult, but actually once you engage in regular physical activity, that can help with pain relief. Start low, start slow, and build up slowly over time. There was a really neat study recently that actually showed that regular exercise leads to the release of morphine-like or tramadol-like substances within your own body to help with pain. So that's kind of cool. So I hope that's helpful for you. So I'm having a look through. I can see Amber Rose has got a question about fibro. I think you mean fibromyalgia. And I think you're probably asking about pain relief in fibromyalgia. And again, I'd always encourage people, as well as looking at medicine treatments that they can discuss with their doctor, to look at what things they're doing in their own life. Now, pain relief in fibromyalgia, there's good data that regular exercise can be very, very helpful. Sleep, nutrition, really important. So that's some of the general things I'd say about fibro. Oh, and Kelly, I hope you don't mind me revisiting. You've updated with a bit more information. You've put it on Facebook, so it's out there already, my friend. So I'll just follow up. You've given me the very helpful information that you're on long-term prednisone at 5 milligrams, which is a lower end of the dose scale. as you didn't want to go on methotrexate. So I totally get it. The methotrexate can sound like a bit of a concerning medication when you first come across it. I personally must have hundreds of patients taking methotrexate as a very, very successful treatment for their rheumatoid arthritis, and it is the gold standard treatment for rheumatoid arthritis. And you know, it's difficult to discuss what your particular concerns were about that medication, but as a rheumatologist, I'd strongly encourage you to think carefully why you didn't want to go on methotrexate and discuss those particular concerns with your, in the first instance, your friendly GP, and they can get advice from your rheumatologist, because I'd really strongly encourage you that this is a fantastic, my go-to medicine for rheumatoid arthritis. So if you're wanting to get off the prednisone, I'd recommend that as your first option. I hope you don't mind me discussing that, but you did put it on Facebook. So I'm just looking through, see more. Josh has asked, Josh has said he's got fibromyalgia. Do you know of any benefits or WINS programs that would help me out? I work 40 hours a week, it's killing me, but I doubt New Zealand sees fibro as a disability yet. Actually, Janine, I'll probably pass that over to you, because I rely on my GP colleagues to help with a lot of the WINS interactions.
Yeah. That's a good question. When if you've got a good income, you're not often qualified for many of the supports. They tend to when someone's not able to work because of the severity of the condition. But we can looking at whether there are solutions around that, because it seems a shame that someone has to start work and get to think they're not working to get support. It's also really important to GP, because there's often some of the PXOs have got different programs or supports that they might go into, and sometimes support from a psychologist or mental health person can be really valuable when you're dealing with fibro.
Hey, Anne, thank you for the feedback on the sound. I'll speak up, and Janine, you'll need to do the same. The sound's going in and out. I just want to come back. Amber had posed a question about fibro and the fried brain, and I think you're asking, does the model of the fried brain apply in fibro? The thing about fibromyalgia is, in all honesty, medical professionals, despite a lot of international research, really don't understand that well what makes some people hurt all over, which you might call fibromyalgia. But I think, having done a lot of reading and following the literature, I think probably the best model for fibromyalgia is that idea of the fried brain. Pain sensitization, fried brain, same idea, just expressed in different ways. I think that probably is a good way of understanding it, Amber. And that's why in fibro it's also important to look at those factors about what's involved in your self-care in terms of sleep, eating. Can't say enough, regular exercise, how important that is. I know it's hard when you've got fibro and hurt all over, but it's a matter of finding something you enjoy, that you can afford, perhaps doing with other people. So you've got the commitment, you have to turn up. I run every Wednesday night with a friend, and it's only because of the friend that I always go. So something that you enjoy, so you actually turn up, so the barriers are small and that you can do more regularly.
We've got a question from Barbara asking about edema.
Oh, that's really challenging. Well, Barbara, first of all, I'll say good on you for asking a question. Scleroderma is not a very common problem, actually. So I'm wondering if you're in the position where the health professionals you're dealing with, you know, they probably haven't seen anyone like you before. She's in Auckland, so she should be able to see a rheumatologist. Or, well, okay. So it might be that your healthcare team's not all on the same page. Actually, might be the problem. I'm wondering if your GP and possibly your rheumatologist know how big a problem this is for you, because in the first instance, they'd be getting some information from a speech language therapist. Maybe they can do some swallowing tests, and then maybe some imaging to understand what's going on. If it's a problem of people talking about surgery and not getting back to you, I'm wondering if this is a problem where a lot of the rheumatology services are not able to see people as often as they would like to. So if you've not got the information you want, I'd encourage you to get back to your GP or ring. Often the rheumatology services have a nurse that's associated with them. You could ring the nurse and say, hey, look, what's happening in this space? Who's going to get back to me when? And they can go and talk to the rest of the team and find out what's going on. Now, Carolyn's told us the sound is lousy. So we're trying. I'm just going to see, where's the volume on this? Oh, it's not. It's this is the volume though. Sorry, tech support is coming to. Okay. Hopefully that's going to work now.
There's a question here from Josh.
Yeah.
Can you see that one?
Can't hear the other lady. Can't hear you, Janine. It's you.
Yeah.
Sound is lousy. Yep. Have any? Oh, the interstitium. Oh, yeah, this was so interesting, Josh. This was in the media a week or two ago. And I did look into it slightly because I've known about the interstitium since I was like a medical student. It's not a new thing. So the interstitium, all it means is the tissue between our organs. So, for example, you've got a liver. It sits up here at the top of your, we say, abdomen, of your tummy, under your rib cage, and it's covered with a little membrane. And then there's a bit of fluid and sort of light tissue between it, and that's the interstitium. It's the stuff that's between stuff. I'm pretty sure there was some study came out in the media last week that they thought the interstitium worked as a connected organ. I did look at the original publication, and it was from one of the perhaps less robust medical journals. So I'd have to look at it again, but I've got to say it hasn't caused as big a splash in medical circles as it's in the lay press. So I've got to wonder how robust the underlying research was. I suspect I couldn't say if it's related to fibro or not. It's probably not the main player. I think the main player in fibro is probably brain sensitization. Oh, wow, Gavin, got a really long one here, which I'm going to be reading as I go. You've got problems with chronic fatigue and fibromyalgia, vertigo and headaches every day for 6 months, varying, osteopath helping, and you mentioned an original head injury. So that's an interesting part. You're sleeping a lot and a lot of time in your bedroom between the computer and bed. Well, first of all, I've got to say, it sounds really, really tough. I'm reading from this as that's quite a big change from your previous life. So I'm really, I'd be quite worried about this scenario, Janine, because it sounds like a really big change from your previous level of function. It's really difficult to give you a lot of detailed advice in this short amount of questioning we've got here, but I'd say you need to get back to see your GP and explain to them what a massive impact on your function your current health problems are happening. Now, sometimes when doctors or healthcare teams can't find one single diagnosis to explain everything, we kind of sometimes not very good at then focusing to, okay, well, how's this person functioning? We can't explain why they're like this. How are they getting on with their day-to-day life, and what can we do to support that? Because there's a lot of stuff we can't explain, and sometimes we need to focus on supporting the person to be the best person they can be and do the things they want to do. Janine, is that a kind of strategy you use?
Yeah, absolutely. The other thing I'd perhaps comment here without knowing the full story is that there are concussion clinics around the country, and there's some excellent support services you can access through ACC. So go back, talk to your GP and see if you can get some more assistance.
Okay, so Mackenzie, I don't know what light process is, so I can't address that one. Maybe if you wanted to put another comment in, we could perhaps get back to you offline about that one. So, and I just...
Karen.
Oh, yeah, Karen. Yeah, so Karen, you've asked an interesting question about the ways people can get support in social media. And there's lots of different ways. It sort of depends what support you want and whether you want New Zealand or international. In terms of support in social media in New Zealand, Arthritis New Zealand which is the not-for-profit organisation whose mission is improving the lives of people affected with arthritis, and by arthritis it's all for body pain. We have quite a good social media presence on, I think this will run on Monday nights, like an online support group, usually from 7:30 to 9:30, so they have an arthritis educator online to answer questions. Not similar to what we're doing today, just not without the camera. In North America, there's an organisation called Key Joints, which again has a social media presence and some online spaces that you can get involved in. And the other big online international collaboration is Patients Like Me, which has some online spaces that you can talk about. And Amber Rose is very helpfully contributing that there's a lot of support groups on Facebook. Some of them will be open, others will be closed. There will be some that are secret. And those ones are the closed and secret ones are usually by invitation. But I suspect you just go onto Facebook and put in some search terms around the diagnosis you have and support group. There'll be lots that come up, and look through and find one that suits you.
I mean, what about some of the precautions when doing that?
Yeah, so I'd encourage you to choose support groups that have some kind of moderation, probably by a health-related organisation, so that you can be sure that some of the advice you're getting is, good advice. But you've also got to balance that when people are looking for support. They don't always want me involved, right? So some of the best support can come from other people like you sharing ideas. But I really encourage you looking at the Arthritis New Zealand Facebook online and their related support groups, because they've got a health professional, often nurses with expertise in arthritis available, so you can know you're getting good advice there. They have, yeah.
Navigator website. So if you go to you'll find a lot of information about all health conditions and medications. So easy to understand information about medicine. Actually, the other thing you've helped us with, Rebecca, is reviewing apps.
Oh, okay, yeah, sure.
Are there any of the ones we've looked at that are worth mentioning?
You've caught me on the fly, and I've not really been thinking in this space today. The organisation from North America I've already mentioned, they have an app which is predominantly a tracking app. But tracking can be useful if you're thinking about what's going on today, how am I going to respond to that and do things differently. And that's probably one of the better tracking apps.
We've got an independent reviews of apps on the Health Navigator website. So again, if you go there, on the top right under multimedia, it says app library, and there's medication apps, there's self-care apps, there's mental wellbeing apps. So some of those can actually be equally as useful, can't they?
Actually, Janine, you don't know this yet, but over the summer we got a grant from Arthritis New Zealand and had a medical student, Devon Farmery, do a review with Devon, who's a physiotherapist that works with me, do a review of pain management apps, and really apps that were focused on self-management, which is just what you're into. And we did come across a really cool one called Super Better, which is really cool looking, and it's got gamification, which is just like craft-based, making you want to play with it more and more. But the thing I loved about it is you could choose what your own goals were and work on things that suited you, so it was very individualized. There's actually a TED talk about it. So if you were looking at apps to help support you with managing pain, I can recommend Super Better. Now, Josh, I'm just going to come back to you because you've been posting again. You're asking about care beyond the GP for fibro and pain. I do know in the Otago DHC there are very good pain clinic, actually, a very good pain service that a GP should be able to refer you on to, or rheumatologists can probably give you an initial assessment. Most of the rheumatology in Otago is through the public hospital system. So talk to the GP about which is appropriate, rheumatology referral or pain clinic. And sorry, we're getting messages about the sound. Work with us on this. Maybe next time will be better. We're learning too, guys.
Sorry.
And Francesca, whom I happen to know is from Arthritis New Zealand, has helpfully reminded us that Arthritis New Zealand also has private Facebook support groups. So if you contact Arthritis New Zealand on Facebook, they may be able to put you out to support groups that are most suitable for you.
There's a long one here from Bob.
Oh yeah.
With multiple health conditions. We're probably not going to be able to answer it because it's quite long, but just see if there's a couple of things we can
take
point
away.
out.
I'll just and maybe Janine, can you just by way of discussion, do your patients ask you in your consultations about apps very often?
Yeah, it depends if you're working. In some areas when I've worked, I've used a lot more requests around information online and about apps. Where I work currently, I'm at one less so. But certainly with a lot of groups, people are getting increasingly interested. When you ask people, do they have apps on their phone? A lot of people have downloaded an app. And the challenging thing is that there's hundreds of thousands of apps. And as an individual, you've got no idea which are the ones that are actually reliable or have any clinical basis to them. And so we've done those independent reviews on the website. There's some guidance and ideas of which you might be better to start with.
Hey, Bob, thanks for your very long and detailed information that you posted. I've got to say, you know, this would be the basis of a 40-minute consultation with me if you saw me as a rheumatologist, and we'd have plenty of things to discuss. What I would say is that unfortunately, in short terms, inflammation can increase your risk of, we say, cardiovascular events. That means heart attack or stroke. But the important thing about risk is it's an increased risk from your background risk. Now, you can't control the increase, but you can possibly control your background risk. So that's your blood pressure, your weight, your cholesterol, your smoking status. You haven't mentioned that. So I think those things are potentially manageable. So you can't, if we can't change the fact you've got these inflammatory conditions. The important thing is this background, and your GP ought to be able to talk about those with you. And I probably can't speak more specifically to your problems there, but it sounds like you need to maybe book a double appointment with your GP and go with a list of your most important priorities. You've obviously thought them through quite well, but I'm suggesting you might need a little bit more time to talk through all the nuances there.
And we've also had requests we can put the links to some of the things we've put on the Facebook, so we'll do that.
Oh, yeah, Mackenzie, that lightning process, that's ringing some bells now. I'm very skeptical of things where people charge you a lot of money. That's my first gut reaction, you know. Who's benefiting here? And what I would suggest you do is ask the lightning process for some background information about the evidence basis for their intervention, and then you take that to your GP. So go back to the lightning process and say, can you tell me what the background is behind this? Private public waitlist, so Timaru. Okay, so yeah, Mackenzie, Dunedin is under a lot of pressure. Timaru is one of our other colleagues, and he does go to Queenstown. So thanks for sharing that to support Josh there. It is a difficult. I'm smiling because I've got a message here that someone wants another session with me. I'm feeling the love. I'm feeling the love. That's very kind. Thank you, whoever said that. Was that a question, Charmaine, or did someone ask for that? Oh, you're going to have another one. Okay. Now, okay. Oh, very good. Oh, sorry. I just saw that. No, I felt the love. I had to say that. How long have we been going for? Oh, wow. We've been going for ages.
Yeah.
I need to be somewhere.
We're going to wrap up. Thanks so much for joining us and for your patience with us. It's actually generated a lot of interest, so we would like to look at live sessions. We'll get the sound and the video quality better for those. We'd love your ideas of what topics or areas you'd like us to cover, and if you can You can find out a lot more information by going to the Health Navigator New Zealand website, Arthritis New Zealand, and the Facebook, and we'll keep the conversation going. So thank you all so much for joining us, and we look forward to hearing your comments afterwards. Thanks everyone. Bye.